without further ado, doctors, let's get right to it. So I think when we do these, it is always best to sort of start at the ground level so folks can kind of build from there. So Dr. Winters, if you'd be willing to, can we start with just a very simple, straightforward, what is atrial fibrillation, or AFib for short?
Sure. I'd like to describe atrial fibrillation with the assistance of a human heart. I should say a model of a human heart. In the normal heartbeat, an electrical impulse is triggered in the right upper chamber. There are two upper chambers. They're each called atria. And this signal spreads across the two upper chambers, allowing them to pump in a nice organized way. The signal spreads down the middle of the heart to where the two lower chambers, known as the ventricles, meet the upper chambers, and then radiates to the two lower chambers so the heart muscle can pump blood appropriately to the lungs and out to the body. In atrial fibrillation, the signals do not spread in one direction across the two upper chambers, but are constantly zigzagging between the two upper chambers. So there are many, many electrical impulses competing with each other, and instead of the upper chambers contracting nice and smoothly, they're twitching. And this leads to a situation where someone may feel excessively rapid and irregular heart beating, and there may be symptoms associated with this rapid irregular heart beating, and there may not be any awareness of it. In fact, some people have the problem and don't sense it at all.
With that in mind, then, I would imagine it may be difficult for folks to take preventative steps about a thing that they may not even know that they have. Are there certain conditions under which someone would get it? Dr. Sussman, why does somebody get AFib?
That's actually a very difficult question. There are a lot of medical conditions that we know contribute to the likelihood of getting atrial fibrillation. Diabetes, high blood pressure, obesity, sleep apnea, common chronic conditions, and people with those are at increased likelihood of getting AFib. Thyroid disease, which is also fairly common, can lead to AFib, but that's often more rapidly correctable, and the AFib may go away with that. There are also a lot of heart conditions that predispose people to having atrial fibrillation. A weakened heart muscle, a thickened heart muscle, or problems with heart valves all can contribute. However, there are a lot of people who have many of these problems and never get atrial fibrillation. And there are a lot of people who have none of these reasons, none of these risks, and do develop atrial fibrillation anyway. So to some degree, atrial fibrillation is its own disease. And there's a lot that medical science doesn't understand yet about why this happens. And hopefully down the road, a lot of better understanding and a lot of newer treatments can follow.
And Dr. Winters, I want to start with you on this next one, but Dr. Sussman, feel free to jump in as well. The risks associated with it. I know that, first of all, any condition that would have an awareness month is obviously something that people need to be paying close attention to. But in terms of how, forgive the term, dangerous it might be for individuals, what are the risks associated with AFib, and what should our audience really know about what can happen to them if they have it?
So, picking up from something that Dr. Sussman said, I would just like to make a point that decades ago, President Bush spoke to a group of AARP subscribers and told them that they should taught them how to check their pulse, and recommended that people check their pulse at least once a month. So because this can be very invisible to patients, I think that we would agree with that recommendation that people should learn how to check their pulse and check it once or twice a month. With respect to problems that can develop from atrial fibrillation, one fortunate aspect is that in many patients, there's no risk of anything bad happening. Some people will simply be bothered by awareness of rapid and irregular heart beating. There may be associated symptoms of shortness of breath, lightheadedness, some chest discomfort, inability to focus and concentrate, and a generalized sense of anxiety. But the most feared risk of having atrial fibrillation is the risk of dangerous blood clots developing in the upper chambers of the heart, which if they become ejected from the heart and lodge in the brain, they may cause a stroke. They can travel to other organs and cause damage of other organs as well. Fortunately, there are ways to predict who are the patients at risk to developing these dangerous blood clots, and factors such as a history of congestive heart failure, weakened heart muscle, older individuals, people with hypertension, diabetes, people who've had a stroke, people who have heart valve conditions would be those at biggest risk and should be on specific medicines to minimize that risk. Other problems that can develop from atrial fibrillation would include a buildup of fluid in the lungs and shortness of breath related to congestive heart failure. If atrial fibrillation is allowed to persist for very long periods of time and the lower chambers of the heart beat fast in response to the upper chambers, a patient may develop a very serious heart condition known as a cardiomyopathy, which can then lead to more serious problems.
Well, and I want to pick up on that, because there may very well be people who are watching right now for whom feel like you're describing them to a T. There may be things that you've mentioned that say, or this is exactly what I'm going through, or this is exactly what a loved one in my family is going through. Who's the first person you should call? Maybe you don't have a relationship with a cardiologist, maybe you have a primary care physician, but what do you do? What's the first step you should take if you feel like some of what Dr. Winters just mentioned is very relevant to you?
Absolutely, starting with a primary care physician, it makes a lot of sense. A primary care physician can check for atrial fibrillation with physical exam or with an EKG or other heart rhythms. The feelings of rapid heart beating or erratic heart beating can be other types of abnormal heart rhythms too. But many of the other symptoms of atrial fibrillation, as Dr. Winters described, shortness of breath, tiredness, lightheadedness, those could be atrial fibrillation, but could be many, many other things. And certainly a primary physician is the best person to start with figuring out, is this a heart issue, is it asthma or some other lung issue, or what else might be going on.
At what point does an electrophysiologist come into play here? And I guess for those who may not have ever heard that term before, for either of you, what is an electrophysiologist?
An electrophysiologist is a cardiologist who has undertaken advanced training, these days being 2 years, specifically in the field of managing heart rhythm related problems, both with medicines and with certain types of procedures. Most people who have atrial fibrillation can have their conditions evaluated and managed by a general cardiologist. Because of the complexity of the assessments involved and the treatment options, it probably is best, if possible, that a patient at least have evaluations from a general cardiologist. Many of these conditions can be handled by an internist or a general practitioner. But once the problem becomes established and the patient is extremely symptomatic and hasn't responded well to certain frontline medicines and more advanced medicines or procedures come into consideration, it's appropriate for that patient to seek out the advice and opinion of a cardiac electrophysiologist.
Now here is the part where I tell you how you can do some of that. If clearly you're following us online because you're seeing this through Facebook Live, although I will also mention this video is going to live in its entirety on our Facebook page, and we can post it to various other digital platforms for us. So if you aren't able to stay tuned through the whole thing, or if there's dropout on your end, you can see the whole thing there. Now you can also, as I was saying, go to our website and you can find the Find a Doctor page right towards the top, which is an opportunity to contact those individuals as well. Moving forward, I want to pivot to procedures and types of treatments. I know that in our conversations we talked about the ability to handle this through both medicine and more physical treatments as well. What are the circumstances under which one might become more necessary than the other? Dr. Sussman, do you want to start?
Particularly in people who are very symptomatic with atrial fibrillation, procedures may become more appropriate, or people who are at higher risk of some of these other complications, rapid heart rates weakening the heart muscle. But typically medications are the starting point, and those can be used to slow down a rapid heart rate, and as Dr. Winters mentioned, anticoagulant, blood thinner medicines to decrease the risk of strokes. In terms of procedures, when we get kind of beyond that, there are a couple of different types of procedures done for treatment of AFib. The simplest is called a cardioversion. That's delivering an electric shock across the chest. So you have the heart inside the chest in atrial fibrillation. And as Dr. Winters mentioned, the heart's rhythm is driven by electrical signals. Delivering a shock externally breaks the atrial fibrillation and lets the heart's normal rhythm resume. So cardioversion works very well, but what it doesn't do is prevent a subsequent episode of atrial fibrillation. So it's typically done with an initial episode of AFib or a second episode of AFib, or in people who have rare episodes of AFib. Or it's done in conjunction with other changes in treatment, such as adding medicines to try to prevent AFib coming back, or embarking on treatment for sleep apnea or some other condition that's a contributing factor. Now, a more complex procedure is ablation, which is a way to try to eliminate atrial fibrillation. And that involves getting catheters into the heart, and we pass these through the veins in the groin. So it's a minimally invasive procedure, no big surgical incisions. We pass the catheters through the veins up to the heart, and they come initially into the right atrium, the right upper chamber, but atrial fibrillation really starts in the left atrium, which is up here.
Mm-hmm.
And the idea is that there are areas of the left atrium that behave abnormally, driving abnormal heartbeats and abnormal rhythms and triggering AFib. And the ablation is a way to modify their behavior to get them to stop doing that. Now, I don't know if these project, they probably don't. There are 4 veins that enter this chamber called the pulmonary veins, bringing blood back from the lungs. And there's a little sleeve of heart muscle extending out the walls of those veins, and this muscle behaves abnormally. So what we do with ablation is deliver different forms of energy, either heating or freezing the muscle, and there are others under development, to basically create a ring of scar tissue in the wall of the heart surrounding the mouth of each of those veins. And that creates a barrier between this abnormal muscle in the vein and the rest of the heart, so that these signals from within the vein can't affect the heart and can't trigger AFib anymore.
We have a couple of minutes left, and I know we've gotten a couple questions submitted to us. So if we're game, why don't we take a couple from our audience and see what folks have to say there. We have a question from Paul. He's wondering, and this is, I'm sure, a common question that many of you may have heard. As cardiologists, do you trust the heart rate measurements from things like smartwatches, wristbands? I know a lot of personal exercise devices now are equipped with the type of technology that may assist in some of this. How useful do you find those to be? Without naming any one specific brand or anything in particular.
There are several devices which can actually record EKG tracings. And these tend to be the most reliable, not just to assess what the heart rate is, but to determine if the rhythm is actually atrial fibrillation or perhaps a normal exercise-related rapid heart beating. They are not imperfect, but they are very good in doing so. To add to that, they can have the tracings that are obtained, the recordings can be printed out, can be sent via text, can be emailed to your care provider. Some physicians, myself included, actually let patients send them to me directly. But any way you can do it, they are pretty reliable. And the best thing is if it says that your heart rhythm is abnormal, and this may change what you're doing, it's best to have it reviewed by a physician or a caregiver who knows how to look at that tracing.
If I can jump on that,
Sure.
Even a much simpler device like a Fitbit, which doesn't record any kind of EKG, records heart rate, usually with reasonable accuracy. It doesn't tell you anything about the rhythm, but if someone says, you know, my Fitbit always shows a heart rate of 60 to 65 at rest, somewhere in that range, and all of a sudden it's 85 or 90, the true heart rate might be faster, it might be missing something, but just that change can be important information that something is going on.
A good heads up to check with your physician. Yeah. Barbara wants to know, how does AFib and atrial tachycardia differ? Obviously, perhaps for some members of our audience, that those may be terms that they're not fluent in, but whoever wants to take a stab at that, I'll leave it up to whoever's more comfortable taking a crack.
These are similar types of rhythms, both rapid rhythms coming from the atria, the upper chambers of the heart. Atrial fibrillation, again, is very chaotic. So there's very rapid activity in the upper chambers, but they're not pumping well, just sort of quivering. Atrial tachycardia is a rapid but organized rhythm coming from the upper chambers of the heart. The rate could be anywhere from 110, which is just a little above a normal heart rate, up into the 200s, 300s, or higher, and can create many of the same problems as AFib. The lack of good pumping strength in the upper chambers, which can lead to the risk of clots, and rapid rates in the lower chambers, which can lead to those other risks too. Sometimes they're coming from the same areas that drive AFib and sometimes drive atrial tachycardia, sometimes different areas completely.
Barbara, thank you for the question, and hopefully that was helpful for you. Tachybrady syndrome. We have a person who's asking for us to address that, and perhaps, I guess it's the connection with atrial fib or similarities or differences. Dr. Winters, Dr. Sussman.
So for the audience, the term tachycardia, or the abbreviation tachy, refers to rapid heart beating. The term bradycardia, or Brady for short, refers to slow heart beating. Many times patients who have atrial fibrillation are administered medicines to slow down any component of rapid heart beating. And occasionally those medicines overshoot and the heart may beat very slow at different times or may stop beating for very brief periods of time. This is most common due to medications that have to be utilized, but sometimes the condition that triggers atrial fibrillation may on its own lead to episodes where the lower chambers are not only beating very fast, but may beat slow. And in such instances, it's often necessary to implant a permanent pacemaker to avoid the heart from getting so slow that it stops and to prevent a patient from feeling very ill or perhaps fainting.
We have time for one more, and again, for those who are still submitting them, we will get you answers as best we can. Certainly, feel free to continue to add them in the thread if you want to, and we can have the doctors. We can ask the doctors afterwards, and we can try to get you responses as best we can. But we have time for one more here during our Facebook Live session. When do you approve of doing the ablation procedure versus staying on medication? So this was a little bit tied to a conversation we were having earlier about the various types of treatment possibilities for patients. So to summarize, when ablation versus medication?
So historically, medications, specifically antiarrhythmic medications, they're called to try to prevent AFib, have been viewed as first line and ablation as second. But that's really changed in recent years. And right now, by professional societies and by most insurers, which is something we deal with in real life, they're viewed as essentially equivalent in terms of desirability as a first choice. Medicines are certainly easier. It's easier to take 2 pills a day than to come in the hospital and have a big invasive procedure done.
Sure.
But a lot of people don't feel well taking these medications. The heart rhythm medicines also have risks, including a risk of more dangerous heart rhythms. So they can't be used in everyone. So certainly for anyone in whom the medicines aren't tolerated or are too high risk or sometimes just aren't working, then ablation is a good alternative.
Outstanding. I want to thank both of you, doctors, Dr. Sussman and Dr. Winters, for joining us for this important conversation. As we mentioned off the top, it is Atrial Fib Awareness Month, so September is the perfect time to be having this conversation. We covered a lot of ground. In summary, and doctors, if let me know if I stray from anything that's relevant here, but atrial fib is a condition that obviously can be caused by many different things, many different conditions. Folks may not even be aware that it's a condition they're currently suffering with. So I think we would encourage folks, if they want to, if they have concerns about this or think somebody in their lives may be suffering from some familiar things you heard here today, that they should reach out to their physician and pursue additional information and resources. Is that a fair way to summarize a little bit?
Absolutely.
Excellent. As we leave you, I want to share a couple final thoughts with you. First, of course, that this conversation, like others we've been having here on Facebook Live, really surround a really important concept that I think the doctors would echo my sentiment here, and that is, of course, do not delay care. If you believe you're suffering from atrial fib or any other condition that requires some management or that you've been seeking care for in the past, now is the time to seek that care. Do not put it off. And doctors, I think I'll give you an opportunity if that's something you want to endorse or talk about the importance of seeking care when relevant. I'll afford you the time to do so if you'd like to.
Treating atrial fibrillation is best performed early on in the course. And a patient who seeks care very early may very well prevent devastating problems, complications, including a stroke. So if you think you may be having this problem, you should seek care now. And here at Morristown Medical Center, the administration has gone out of the way to ensure safety of all patients coming here and expedition of care, especially in this troublesome COVID-19 era. John, would you like to add to this?
I would absolutely agree with that. The risk of stroke with AFib, again, one of the most devastating risks. And if you're in AFib and you don't know it and aren't treated, that risk is there. The other things we do to treat AFib, the medications, the procedures, all work better earlier in the course. So definitely something not to wait on.
Well said, doctors. Thank you. If you're looking for more information about the Morristown Medical Center cardiac rhythm program as it relates to atrial fibrillation, here are just a couple of things to keep in mind. There is a comprehensive atrial fibrillation evaluation and management program here, dedicated full-time core electrophysiology physician and nursing teams. There are nurse navigators to enhance care, high-quality catheter ablation outcomes, some of which we were talking about earlier, left atrial appendage closure or Watchman capability, inherited arrhythmia program. There's participation in pivotal NIH, National Institutes of Health, and industry trials, and centralized on-site pacemaker and ICD surveillance program information. So certainly a lot to benefit from joining if you need some assistance and to learning more about. Go to our website, atlantichealth.org, where all of these things are available for further information. Doctors, thank you so much. I appreciate your time. My name is Luke Margolis. I'm the Corporate Communications Director for Atlantic Health, and we'll see you next time.